Hello and welcome everyone. I want to thank you all for joining us this evening. I appreciate the opportunity to be with you all. My name is Joe Willardson, and tonight we will be discussing new treatment and technology for hypersensitive patients. Before we get started, I practice here in Las Vegas. I'm a graduate of Loma Linda University School of Dentistry and went on to focus my practice in occlusion, cosmetics, and biomimetics. I currently teach with my friend and mentor Dr. Clayton Chan here at Occlusion Connections, and I'm a certified instructor through the Allum and Della Perry Centers for Biomimetic Dentistry. My practice and work are something that I'm very passionate about, but I'm not always so serious. Living here in Las Vegas, I've always been passionate about racing. And so that's one of the other things that I'm really into. And running a race team in racing is a lot like running your dental practice and practicing dentistry. They both take a lot of heart. And so before we get started, I want to share a little story. This was my very first race car, and I got really into it. I had my sponsors lined up, and I'd been tired of crashing on motorcycles and skis and BMX bikes, so I decided it was time to get a cage, a little more protection. So my first race, we were in Mexico with a friend of mine, and about halfway through the race we ran into a little bit of problems, just like we do in our practice. And sometimes we fall down and we crash and we burn. And so this is what happened to me and my first race car. So you can see it was pretty much a total disaster.
You brought a really big one with you.
But just like in dentistry, we have to pick up the pieces and move on. And one thing I've learned about racing, and it's just like dentistry, is you're always looking ahead. And you're always correcting and always maintaining balance. And you have to keep doing what you love and stay passionate. And when I was introduced to this new technique of desensitizing, it's not something that I regularly did in my practice because I always felt like they didn't work. So I was given some new products and introduced this new technique. And I want to share with you an experience I had with a patient of mine, which really kind of got me into this. And so this is just a brief video where I had picked up my camera on one of the first times that I had the opportunity to use some of these new products. And I want to share with you how this experience went.
My teeth being seen because it's sensitive. It's mostly
is volume okay there for everyone?
But also you can feel in my front tooth. If I have to drink cold, I have to use a straw. It's been about 2 to 3 years since it began.
So Suzette is sensitive there.
Yes.
How about on the side?
Yeah.
Very sensitive.
The one here, the one that you just put in here.
Okay. One more time.
Okay, that one.
That one.
Yeah, that's
Okay.
one.
All right. Okay. Good.
Which one?
Okay. This is after.
Better.
Better. You feel the difference?
Difference. Yeah, I can feel the difference. Yeah.
That's
better?
a lot better. Before,
yeah.
Yeah.
That's a lot better. More tolerable. Oh, that's a lot better. I couldn't do that.
Not before.
Not before.
Let's try one more time.
Yeah. That's way better.
Okay, great. So it's kind of funny. I posted that online, and I could always tell when someone would comment if it was a dentist or not. Some of the comments were, "I can't believe you're blowing that much air on the patient," and the other one was, "Yeah, that always works when you get them numb first." But I can tell you, I didn't get her numb. That actually is exactly how that played out. So let's talk about our outline, and this is what we're going to go over tonight, discussing hypersensitive patients. First, we're going to talk about diagnosing, And we're going to introduce and incorporate some effective techniques and products to treat hypersensitivity. So in our diagnosing, we're going to talk about recognizing the signs and symptoms, occlusion and how that affects hypersensitivity, operative procedures that affect hypersensitivity, and exposure, for example, gum recession and more procedures related to perio. We'll also talk about different techniques and the mechanisms that we have now available to us, the types of techniques, and comparing each of the different products that are out there. In addition, we'll talk about some of the challenges that each of these products have, everything from immediate relief to their effectiveness to their safety and ease of use. And we will also talk about some new solutions such as introduction to a new hydroxyapatite treatment, the features that that has, and the clinical applications. So just a quick review. We're going to talk about the dental tubules in the anatomy. Here we have our dentin. You can see my cursor here. The dental tubule. The tubules are actually larger in diameter and more porous as we get closer to the pulp. And those are related to the odontoblasts and how the nerve innervates around those odontoblasts. So just a real quick, I know we've all seen slides like this a million times, but just wanted to kind of give ourselves a little reminder. So let's talk about diagnosis for a second. You know, in my office, and my background is very heavy into occlusion, and so much of my practice, I deal with occlusal problems all the time. And this is something that I use with my patients quite a bit. I will go through these signs and symptoms when I'm looking for TMJ problems or headaches and neck pain and that sort of thing. But over here on the right side of the column, you'll see a lot of the intraoral signs of malocclusion. And I'll discuss these with my patients as we see these problems start to arise, because sometimes these have a direct effect on sensitive teeth or hypersensitivity. I use this in my initial appointment. I use it in combination with photos. My assistant usually helps me fill this out. It's great for patient education, reducing my liability as a doctor, and helps weigh the risks of doing habitual bite dentistry, and it creates more value to the patient as well. All right. Form follows function. You know, when our patients have malocclusion problems, and we see those chewing muscles, the masseter and the temporalis, start to fire, when the teeth don't line up properly, we usually see one of three things happen. We'll either see wear, and we start to see wear facets and that sort of thing. You can see when things don't line up properly, there could even be tooth movement. This can be a big problem with hypersensitivity. And also, if the tooth isn't going to wear, or if it's not going to move, something's going to give. And we can see fracturing take place, and obviously that would be a problem with sensitivity as well. Those are actually great slides that I share with my patients as well, because it helps them get an idea of kind of relating to what I'm talking about. This was a really cool study from Dr. Pascal Monnier, and it comes from one of his books on biomimetic dentistry. And the study shows where those forces translate when the occlusion is not ideal. And sometimes we can't get ideal contacts. And so what ends up happening, I'm going to show my cursor here, all those forces are translated down near the base of the gum, unless we have ideal contacts. And so all those forces and stress come right down near the gum line, where we end up having a lot of exposure and sensitivity. And one thing that I like to do when I'm teaching my biomimetic courses, I really try to stress to doctors, look, let this image burn in your mind, because this is what's happening when we're crowning our patients or putting new fillings in, and we can't get all the occlusion that we want. So we really need to be conservative and pay close attention to what's happening here with our patients and their bites.
Abfraction
Again,
is a gum recession
that
and
study.
loss of the enamel that results from
also a
stress
great
forces caused by
animation that I share with
bruxism
my
or any
patients that
kind of
talks about
misalignment of the
abfractions.
teeth.
In those, I guess, prematurities
Abfraction is a gum recession and
occlusal
loss of the
contacts
enamel
where we
that
see that
results from stress
abfraction happen. Let's
forces
play that
caused
again.
by
That's kind of fast.
bruxism or any
You
kind
can
of...
see where that abfraction starts to take place, and that tooth starts to break down. So as patients understand this, and as we as dentists understand this, we can treat hypersensitivity from different angles, and maybe it's not always something that we treat with a product, but maybe it's something we address in our clinical applications with treating the bite. Here's some different signs and symptoms. Flared anteriors, you can see back here in the back there's no posterior support, and as a result we have all these forces that's causing a lot of that gum recession. I mean, obviously the patient's hygiene needs to be in order as well, but you can see the brunt of that is here in the anterior. Wear facets, these are all things that we could be looking for. Abfraction, this is actually a patient of mine who is one of Las Vegas's top architects. And, this is obviously a real sensitive area for him. It's not decay, it's all abfraction coming from the bite. He had headaches, neck pain, and all the classical TMJ or TMD symptoms as well. Bicuspid drop-off, which means here in the back where these bicuspids drop off and we have these higher anteriors, which leads to less posterior support. Missing posteriors, again, less posterior support, putting a lot of stress up here on the anterior teeth. Operative issues. Obviously we see this quite a bit, and when we see this type of leakage, we as dentists know exactly what's going on underneath there. When we look at the x-ray, it doesn't look so bad. We can see a little shadowing here and some calculus there. But it's not until we really get in there and start cleaning all of that old material out and going down even further and seeing where this sensitivity could be coming from. No matter how much product we put on these teeth before we get in there, we're never going to reach that until we get it all cleaned out. You know, as the patient bites down on these weakened teeth, you can see here where we get microfractures, and that leakage can be measured in microns, but that still gives the patient some hypersensitive issues. This is a really kind of a fun test that we do when we teach our biomimetics course. You know, when I got out of dental school, I graduated in 2000, and at the time, posterior composites were still kind of taboo. It wasn't really taught, and they said, look, don't do posterior composites. So, you know, naturally as things progressed, and I got out of dental school and I started doing posterior composites, I would run into problems with patients being sensitive, and I didn't know why. I did everything that I thought that I knew how to do. But if you get a chance, grab a carpule and share this with your staff. And what you're seeing here is a carpule that has some flowable composite. And then I've just taken some caries indicator here and cured that composite. And you see the shrinkage of the composite, which allows for that micro leakage, whether bacteria or sweets, or you can see how this would be a problem with sensitive teeth. So in our diagnosing, we also need to take into account how are we completing our restorations? Are we getting the bonds that we need to? Are we layering incrementally? Or are we doing bulk fills? Let's say we do have a good bond. This is another exercise where I've taken the glass carpule sandblasted this area and etched it and bonded it, and have done a bulk fill restoration with inside the carpule itself. And you can see the stresses that happen on that surrounding structure. So with that composite shrinkage, it's also going to be putting a lot of stress on the tooth. So you can see these are some things that would cause hypersensitivity that we could take for granted just because we think we're doing things properly. We may be causing stresses or leakage that we don't even know about or even aware of. So you can see again, here's the different examples of that composite and a bulk fill versus something that doesn't have a great bond and how we can get that leakage. It's interesting when you do this project, or if you try it, you'll notice that the cracking doesn't happen all at once, but that composite will start to shrink slowly over time. Whitening. One of my biggest questions was always, well, if we are whitening enamel, then why are we getting sensitivity? We're not. The dentin is already covered. We have this shell of enamel that's covering the dentin. Then why are my patients getting sensitive? Well, there's actually a really good paper from Rod Kurthy, the white paper, and the folks at Core Whitening. And I'm not paid by them at all, but I just thought this was a great paper. The theory is that as there's microfractures in the enamel, that gives a passageway into the dentin. And when we're using these strong peroxide gels, that can seep through and cause some of that sensitivity that our patients are feeling. And I especially notice that when we do in-office whitening, because my patients will complain of zingers and that sort of thing. So with these new techniques that we're going to talk about tonight, there's actually some things you can do to block or seal off even some of those enamel microcracks, fractures. Scaling. Obviously, as we get into scaling, as soon as when this patient shows up into our door as a new patient, we tell them that they need some scaling. And after our poor hygienists have gone in there and done their job and done everything they're supposed to, and the patient is sensitive, they're automatically going to assume that it's our fault. So these are some other things that we need to take into account as we address the issue of hypersensitivity. Speaking of with our hygienists, the insurance codes for treating hypersensitivity are 9910 and 9911. And what I've noticed is some insurances will pay those fees or pay on those codes and some won't. The approach that my office takes is we say, okay, look, we notice you're having hypersensitivity or your teeth are sensitive. So we have some new techniques and products that we're going to use. And we quote them the fee, what their insurance would pay, what their out-of-pocket might be if the insurance doesn't cover it. And when we use those procedures, and let's say that it doesn't work, at that point we tell the patient, look, it didn't work. We're going to refund your money. This isn't something that's going to work. And maybe we misdiagnosed it. Maybe we're chasing something that was a bigger problem than simple hypersensitivity. The nice thing about that we want for our hygienists to be able to apply is we want something that's hydrophilic, something that we don't have to dam off and that doesn't cause irritation to the gum, something that doesn't require curing. And the newer treatments are something that would form a hydroxyapatite plug, or combined with fluoride. When our hygienists use fluoride treatments, it will actually create a fluorapatite, something that's extremely strong. Obviously, gum recession. That's something our hygienists and we deal with quite a bit. So an incorrect diagnosis. If we do these treatments and there's still sensitivity, we have to look a little bit deeper and decide, okay, where is this pain coming from? Maybe the pain is not originating from that tooth. Or maybe we have a cracked tooth. Maybe there's a crack in there that we don't see. or maybe there's irreversible pulpitis, or maybe it's referred pain from somewhere else altogether. So an incorrect diagnosis could be any one of those four things, and that is something for us to look at elsewhere. So let's go over some of the actions of some of the hypersensitivity treatments that are out on the market right now. These are two ways that most treatments work now. It's either occlusion of the tubules, where it's going somewhat inside the tubule itself and blocking that process, or it's covering the dentin surface altogether and bonding to the hydroxyapatite in between the tubules. So those are two common mechanisms of the products that we have out there now. Here's some types. The glutaraldehyde type, it's occlusion in the dentin tubule by coagulating with the protein. An oxalic acid type is occlusion of the dentin tubule by an oxalic acid. Basically, the acid gets in there and creates a tube. A fluoride type, occlusion of the dentin by fluorine compound, and a resin type, where basically we're creating a hybrid layer and creating a bond over the top of all of those tubules itself. And these are just some different companies that are associated with those types of hypersensitivity treatments. Again, if you look at this group here, these are the products that are the glutaraldehyde types. These are the fluoride types. Here's an oxalate. The toothpaste like Sensodyne will use a potassium nitrate. And basically what's happening is that potassium nitrate is numbing the nerve over time. So those are something that aren't quick acting. It's something that has to develop over time. Now, with some of the newer products, especially TeethMate from Curare, we're actually creating hydroxyapatite in the tubule itself. So we're using a tetracalcium phosphate and a dicalcium phosphate mixed with water and accelerators to create a very hard, durable plug inside the tubule. Now, the advantage is that it suppresses the hypersensitivity by sealing the dentinal tubules and microcracks in the enamel as well. So when we talk about bleaching, this is going to be helpful when we're doing in-office bleaching because it will also get into those microcracks in the enamel. So the hydroxyapatite actually crystallizes inside the tubule itself. Now, how do we know that that's hydroxyapatite? Through X-ray diffusion analysis, we see the hydroxyapatite peak here. Now, this is something that in this study I thought was pretty interesting. If you look at the electron microscopy slide here, you can see that this is after 5 months of storage in artificial saliva, whether that even an acidic type of environment, and those tubules have still stayed sealed up, so it's an extremely strong product. If we can create that hydroxyapatite in those tubules, that's exactly what we want to do. Now, we kind of went through some of the actions of the different desensitizers. Let's go through some of the challenges that we all face with the products that are out there now and what we have available to us. So there was a survey taken on 42 dentists from Japan, and the number one challenge that we face is the short period of effectiveness. So 26% agreed that the biggest problem is it doesn't last very long. 24%, it wasn't very fast acting. It took a long time to see results. And 16% was the effect on the soft tissue, feeling like there was some irritation to the soft tissue based on the products that they were using at the time. 13% were concerned about the film thickness of what was being applied to the dentin. Another 13% on cost, and 2% on the negative bonds, or could it affect the bond strength of the restorations? And 5% was other. So pretty interesting to see that almost half is due to a short period of effectiveness not lasting very long, or it taking a long time. So these were two big hurdles for the companies that we work with for them to overcome this. So let's talk about why these products don't always last so long. If you look, this is a study that was done using different acids such as orange juice and Coca-Cola, and there's 4 different products here. If you look here in the upper left-hand corner on the pink study, you can see the open tubules, and then directly after that you can see the treated tubules. And if you look closely, you can see the particles that are blocking those tubules. After 5 minutes in orange juice, you can see that those tubules are pretty much opened up again. And treating with a soda like Coca-Cola, not quite as acidic as orange juice, or it didn't have quite the effect that the orange juice had, but you can still see those tubules have opened up again. This is a different product, almost no coverage, just very little in the treated tubules, and again, you see in the acidic environments, all the way across the board, from the blue to the green to this other blue study, that those tubules are just opened up again. So that short period of effectiveness has a lot to do with what our patients are doing once they leave our office. What kind of environment are those treatments being subjected to? Okay, so here's a closer look. This is an oxalic type of treatment. You can see initially that tubule has been blocked. 3 days in artificial saliva, you can see that the tubule is open. But look up here where my cursor is. They're actually opened up even more. And the problem is this is an acid. So what's happening is once that plug has been removed or the occlusion is gone from the tubule, we've created a more open environment, so now even more transmission of fluid into that nerve is going to cause even more sensitivity. So we see a breakdown in, with this type even after 3 days in just saliva. We go over to a resin type. We see pretty good sealing of the tubules here, but after brushing over time, we see that those tubules open up again. And these are the reasons why we have to keep treating and retreating these patients for hypersensitivity. And I've been there. I've been frustrated with this. I've used lots of different products, and I've always had to retreat. So I've always thought it would be nice if I didn't have to do that. So again, here's the glutaraldehyde types, the different types, and the challenges that these types face. So with the glutaraldehyde product, there's a lot of irritation that can come from the glutaraldehyde type products, and it can be irritating for the gums. I know that when I've used these types of products in the past, when I'm seeding restorations or bonding, I'm always trying very careful not to get that near the gum, because I certainly don't want any bleeding when I'm trying to bond something. Even with a rubber dam on it, it can be a challenge. The other thing about a glutaraldehyde type is that it will quickly go away unless it's covered with a resin coating. So it's necessary, to make sure that when we use a glutaraldehyde type, that it's sealed off with a resin coating. And this is something that typically a hygienist can't do. Is if you're trying to coat a cervical area of the tooth, that becomes a challenge. Oxalic acid types, like we talked about, it is an acid, so it can open up those pores and create more sensitivity later on. It's irritating to the gum and will demineralize the tooth when applying the product. In the fluoride type, it has a low desensitizing effect, takes a long time, and needs multiple applications, and mostly used for early lesions. So that's doesn't really plug up the tubules very effectively. And a resin type as well, difficult for hygienists to justify using this. High recurrence rate, hard to apply to gingival areas, and can cause plaque adhesion. So we've talked about the actions, the challenges, so let's talk about the solutions that are out there now. And we're talking mainly about the new product from Curare with the teeth mate desensitizer, which actually, as we showed earlier, will form those hydroxyapatite plugs. So the goal was to create something that our hygienists could apply, or our assistants. It's not irritating to the gum, and reduce the recurrence of hypersensitivity during the short term. So by using hydroxyapatite plugs, this has been a great solution. This is actually that patient that you saw in the video in the beginning. This is me applying that product to her. I didn't have video when I was applying it, but this is how easy it is. Basically a liquid and powder. If you notice, I'm not really isolating anything. I don't have a rubber dam. I'm not real concerned about any liquid or water being in the area. It's very easy to apply. So it was asked, there was a survey asked, I believe by a dental product shopper, for what procedures do you typically use a desensitizing agent? 39% said whitening, 32% after scaling. In general sensitivity, 90% of us are using some sort of desensitizing agent under amalgams, under indirect restorations, and under direct restorations. So it's something we use quite a bit, but for me, there's always been that frustration of it, is it going to last? Another survey was done on the teeth mate desensitizer, and 92% of the dentists agreed that teeth mate was very effective. So in the satisfaction survey with the hydroxyapatite desensitizer, you can see over here on the left-hand column in the red figures here how well the application of use is, everything from excellent to good, treatment time, excellent to good, effectiveness, biocompatibility, overall satisfaction. So it's been a great product. The use of the hydroxyapatite plugs has really been good. They're very durable. It fills the tubules well. There's no film thickness, and there's no soft tissue blanching. So it's something easy for your hygienist to use. The other thing I like about this is I never have to worry about the influence of bonding, because when we bond, we're bonding to hydroxyapatite anyway. So it's something that I can apply very comfortably even right before I'm about to bond something. Whereas before I was always a little bit nervous to use any of the other products, in the back of my mind thinking, okay, well, how is this going to affect the bond? How is this going to be for me long term? Use it in a number of applications: exposed dentin, scaling, root planing, whitening. This is kind of interesting. Yesterday I had a patient that we were seating 8 posterior crowns, and when she'd come in, I had my on the right side, lower right side, the temporary was very loose, so it pulled right off, and I said, well, are you sensitive right now? She said, yeah, I'm a little sensitive. And she said, well, I don't want a shot. I don't want to be numb. I don't want to walk around being numb all day. And I said, okay, well, let's try this. So I got the desensitizer out, and I put it over the teeth, the exposed dentin, before I had even really rinsed anything off. I said, let me see how well this is going to work. So we applied the desensitizer on the exposed dentin right after I'd taken the temporary off. The first time I went in there pretty cautiously and rinsed it off. I said, okay, I can still feel that a little bit. So I applied it one more time. Still, it's better, but I can still feel it. By the third time I applied it, she couldn't feel anything. She said, this is great. I was able to dry the tooth off. I was able to add my chlorhexidine, clean it, get all of the temp cement off. A lot of times with my temp cement, I'll use a diamond ultrascaler. And I was actually able to go in with the diamond ultrascaler and clean off all the excess temporary cement after I had put the desensitizer on. It's like, this is awesome. That right there was a huge testimony for myself. And I was able to actually do that on the other side, and we're able to see all 8 restorations without getting her numb. So that I thought was extremely cool. My background is in biomimetic dentistry, which means to mimic nature. We are creating hydroxyapatite. So this is something that's very biocompatible. It's something that's going to bond well. And again, I'm only using cheek retractors here. It's very simple to use. Going back to how this affects the bond, if you look at this, you can see the control is in light green and the experimental is in the dark green. Not that this is a game changer, but you can actually see on most of these the bond strength goes up when using this. So remember, we are bonding to hydroxyapatite. So if another image can burn into your mind, this is one of those images where you can rest assured and sleep well at night knowing that your bond strengths are going to be okay when using this hydroxyapatite forming product. Here you can see again the plug in the dentin there. Okay, so this is the same type of experiment that was done that we looked at before with the oxalic acid type. You can see where the plug had opened up over 3 days in artificial saliva. So that's just after 3 days. Now if we go back over here, you can see the hydroxyapatite plug is still good, if almost looking more dense after 5 months in the artificial saliva. So these are the sort of things that I'm looking at that have been really impressive to me. And you can see here where the occlusion of those tubules is almost, or looks more uniform and stronger than it was done initially right after they had been placed. Whereas we go over here to the other side and you can see that obviously they were open, and again they're even more open because of the acid opening up the circumference of that tubule. This is after brushing, comparing the hydroxyapatite type versus the resin type. Again, opening of the tubules over time. And that's from manual toothbrushing. One of the things that makes this especially unique is the hardening agent. So as you're placing the desensitizer on the tooth, it's hardening almost immediately. It begins very fast. And so that's one of the reasons we're seeing such a dramatic, accelerated response in the effectiveness, is because it's working extremely fast. So that was one of the goals, I'm guessing, from Curari's when they made this, is it needs to work quick and it needs to be strong and long-lasting. But drastically shortening the hardening time, less than 30 minutes. Again, how the hydroxyapatite sealer works with your bond strengths. More or less sort of the same chart that we looked at before, but again you can see the rise in megapascals in your bond strength. So the goal was to develop something that didn't irritate the gum, something that was easy to use for the hygienist, would last a long time and would be effective immediately. So we've put together some troubleshooting problems. The complaint being, well, the teeth mate desensitizer didn't work very well. Some questions to ask: was the dentin surface clean? Any biofilm, plaque, or saliva? You have to make sure the tooth is clean before using, so make sure there's no slurry that's penetrating into the tubules. The other thing to ask is, how long was the desensitizer rubbed into the surface? It needs to be rubbed in for about 30 seconds per tooth. Now, here's the thing that I've noticed, is when I'm using this product, it usually takes me twice. So I'll apply the product if the patient is extremely sensitive, and I actually have another video here to show you here in a second, but I'll put the product on, rinse it, test it, put it on again, and I would say probably 80% of the time I'm good to go right there. We've got occlusion of the tubules, I can move forward. But there is another percent of the time where I have to add a third, sometimes a fourth layer. And if I go beyond 3 or 4 layers, then I start to think to myself, okay, well, maybe there's a different problem here. The other thing is difficult to mix, the slurry is too dry. Well, when you have the powder and the liquid together, you just have to make sure that you're doing the liquid first and then putting your powder in. It's easy to mix. Another problem is the applicators they give you sometimes they're really flimsy and flexible. So a lot of times I end up using a micro brush and swapping that out for something a little bit larger and a little bit more sturdy so I can really feel that scrub in to the tubules. Some other reasons for maybe not getting immediate relief: didn't clean the dent properly, mixing too much liquid, not enough pressure during application, or applying in too short a time. Maybe you're not going the full 30 seconds. And like I said, for me anyway, it takes about 2 to 3 times to get a really good occlusion. Or, maybe it's an incorrect diagnosis. Maybe we're treating the wrong thing. So before I go, this is another example of a patient that had come in. She had broken off one of her PFM crowns that I did not do. You can see it's been aggressively prepped, and the patient came to our office with the tooth in hand and asked, hey, can you re-cement my crown? Well, of course, I look at the crown and the tooth, half the tooth is still stuck up inside the crown. Obviously, we would want to treat this, in my opinion, maybe even an implant or something that would be longer lasting for the patient. But we thought, what the heck, let's try it. Let's see how long we can get this to bond in and stay in place. So, again, the patient didn't want to be numb. And the tooth, which was there, was real sensitive. So let me show you how this went down.
There you go. Just a little further. Why are you okay?
Good. Okay, here comes. Is that okay there? Mm-hmm. You feeling that like you were?
No.
Doing okay there?
Yeah.
Helped out a lot?
Yeah.
Good. Great.
Yeah, that right there, that's what makes this product that I've been pretty excited about it. You can see how easy it is to use. That actually, my assistant was actually applying the product while I held the camera and filmed this, but I've been extremely happy with it, and I know that this is going to last. Actually, this was done probably 3 weeks ago, and the patient came in yesterday. Tooth is still in place, amazingly, even though we don't have much to bond to there. But absolutely no sensitivity, no pain, and everything is going great. So that's a bit about it. Any questions at all? I haven't gotten any questions during the lecture here, so I appreciate your guys' time. We've got Dr. Clayton Chan here. Thank you, Clayton. The question is, what is the ratio of mixing of the agents? There's a scoop on each. There's a large scoop and a small scoop on each side. And on the small scoop of powder, it's 1 drop, and on the big scoop of powder, it's actually 2 drops. Very easy to mix. Great. Thank you. If any questions, feel free to contact me. There's my information. And I appreciate your guys' time, and have a great evening. And, let's see. One of the questions is, who supplies the TMD or the toothmate desensitizer? That is through Curare. That can be, I imagine, through any of the distributors, Henry Schein, Patterson. So that's where you can get the toothmate desensitizer. If not, the best thing to do would be to contact Curare and find out who your local rep is. One of the questions is, how many teeth can be treated in a kit? That is a good question. I would say that the bottle and the one bottle or one kit will last me about a month. I apologize, I haven't counted the number of teeth, but yeah, I can say it lasts me about a month, but I use a lot of it. Next question is, what is the shelf life of the product? That is a good question as well. I don't know the answer to that, but I can tell you this. When you're working with the product, once you mix that product together with the powder and the liquid, you've got about 10 minutes to use it. Oh, I've got some great questions here. I'm going to try to get to all these, but they're coming in pretty fast. So the cost of application, I believe, is about 80 cents per application, so it's very cheap. And the next question to follow up with that is, how much do I charge per patient? Now, the insurance that I'm contracted with pays anywhere from $50 to $80 per application, which is great. So, it's as a profit center. Not saying that's what we're trying to do, but the margins are very good. So, if the insurance isn't going to pay for it, I typically will charge the patient anywhere from $25 to $40 per tooth. If I'm doing a whole quadrant of teeth, then I'll break it down. Because it's so easy and fast to work with, just use your discretion. I would say for a quadrant, I might charge $100 to do, 4 or 5 teeth. Next question was, when you submit to insurance, do you submit by tooth or quadrant? We've been submitting by the tooth. Okay, looks like that's it for questions. If anything else pops up or if anything else comes to mind, be sure to contact me. Be glad to talk to anyone. All right. Thanks a lot. Appreciate it. And everyone have. Oh wait. Is this product available overseas in Australia? Yes, I believe that it is. Again, that would be something to ask the curare, your local curare rep. But I'm pretty sure that it is. All right. If you have any questions, be sure to email me, and I'll be glad to get back to you. Thanks, and everyone have a great night. Thank you.